Thank you for inviting me. And it really is incredible how many people are here and how this community comes together so well and has stayed together over the last roughly 4 decades for us. So just going to acknowledge Galina, who you know was supported by CRN about 10 years ago for a fellowship to concentrate on cystinosis. And some of the work that I'm going to show you today is her work. You know, Rachel Bishop is our ophthalmologist for many years. Joy Bryant was a research nurse who takes care of our patients at the NIH. Terry Vilbeau did a lot of the molecular biology that we've done, and May Malikdan has done some of the bench work. And Katharina Hohenfellner contributed some of the screening work that I'm going to show you. And then NICHD and NHGRI supported me over the years. So they gave me my salary, and you know, at the NIH, they let you do what you want to do, as long as you have a report every year and a report to the Board of Scientific Counselors every 4 years. So there are some things that are a pain in the neck, but still, it's a wonderful thing. And then all of the cystinosis families that I've seen over the years have brought me so much joy just to be associated with them. So I really want to thank you all for that. So I'm going to talk about the natural history, about cysteamine, about the genetics, and a little bit about newborn screening today. So this is a recessive disorder, meaning that you have to have both copies of the CTNS gene basically ruined by the genetics of it. And you can see it's 1 in about 200,000. It's a lysosomal storage disease. The lysosome is a compartment inside the cell that's acidic, and it breaks down large molecules into small molecules. It has a lot of other functions, but that's one of the main ones. And in fact, all of the previous lysosomal storage diseases were found to be due to enzymes that fail to break down those large molecules into small molecules. Then along comes cystinosis, and instead of being an enzyme defect, it's a transporter defect. Now, the cystine can't get out of the lysosome because there's no transporter there. So this was the first transport defect causing a lysosomal storage disorder. And so the cystine accumulates. And one thing about cystine is it's poorly soluble in water. It's only soluble at about 1 millimolar. And because of that, it can crystallize in some of the cells. It doesn't crystallize in all the cells, but some of them. I'll show you some pictures. And the treatment is really twofold. One is to take care of all of the organs that have been damaged by, for example, replacing the electrolytes and the nutrients that have been lost by the kidney, or replacing the thyroid hormone, because the thyroid is destroyed sometimes. But the second is directed at the very basic defect in cystinosis, which is to say the storage of cystine in lysosomes. How can we reduce that? And we can do it with cysteamine. So I'll show you about that as well. So here are some of the crystals, and it's a little hard for me to see here, but that gets bone marrow first, and they're typical hexagonal, rectangular, and this is in the liver, this is the kidney, the glomerulus, and this is an electron micrograph showing the crystal essentially pushing out of the borders of the lysosome. And this is a scanning electron micrograph too, and each of those big cubes is a cystine crystal. So what's the history of a typical person with cystinosis? Well, the kids are essentially normal at birth. You can't tell that there's cystinosis by virtue of any of the physical findings. Now, there's probably some damage to the kidney at that time, even at birth, especially with respect to the tubular function of the kidneys. But it's about maybe 6 months of age, maybe 9 months of age, that kids with cystinosis start to not grow as well as they should. So they fall off their curves, and they'll often be drinking a lot by that time to make up for the fluid losses. And sometimes they get dehydrated, and they'll have low potassium and things of that sort, acidosis. And then there's the growth. As I say, they fall off their curves. And then a few years later, like maybe 3, 4, 5 years of age, they get photophobia because the crystals in their corneas begin to hurt them, and they squint, and they don't like the light. And then around age 9 or 10, The natural history of this, meaning without cysteamine therapy, is that the individuals will lose their kidney function and require either a kidney transplant or dialysis. The first kidney transplant was done in 1968 for a cystinosis individual. And so that defines the modern era of kidney replacement. And then when the kids survive because they've got a transplant or for other reasons, the natural history is that they can have some of these complications, calcifications in the brain, diabetes, some retinal issues, swallowing difficulty, a myopathy or muscle disease, pseudotumor cerebri, which is increased pressure in the brain, liver involvement, and coronary artery calcifications. Now, these do not occur in every individual, and these complications were discovered in the late 1980s and 1990s and the early 2000s, meaning that all of the patients who had these had not received cysteamine, at least to any great extent. So I do not think that the people in this room are likely to have or get these complications anymore if they take cysteamine. Some of the older patients might have this. So here's some kids. He's 11-month-old and a 7-year-old. You can see the 7-year-old is short. And then there's rickets. And rickets is one of the reasons why kids with cystinosis don't walk at a usual age, because rickets hurts. And so you can treat that with a phosphate replacement. You probably know most of this stuff. But the rickets is typically, here. So it has fraying of the epiphyses, which is the growth plate. It has widening of the metaphyses, which is right close to that. And then a washing out of the bone. And again, the treatment is a little bit of vitamin D, but also phosphate is the most important thing. And here's a little boy whom I saw when he was 20, and a picture of his father who walked across the country to raise money for, at one point, a transplant for this boy. And of course, he's giving water as a reflection of the fact that the kids need to have free access to water because they urinate so much. And this is the growth curve for cystinosis individuals compared to a normal growth curve. Again, the kids are normal size when they're born. By 1 year of age, they're at the 3rd percentile. And they subsequently grow at about 50 to 60% of the normal rate. So they keep falling off and falling off like that. This is, again, without cysteamine. So the non-renal involvement, meaning after transplant in general, again, there can be calcifications in the basal ganglia, which is a certain part of the brain, and also in the paraventricular regions, so around the ventricles. It's characteristic. And again, it doesn't happen in everybody. It doesn't happen in, I haven't seen a new case of this in probably 15, 20 years. So let's put it that way. There can be rare retinal blindness because the cystine does accumulate in the retina, and we've occasionally even seen crystals in the retina. And then the corneal crystal is common. Everybody gets that by 16 months of age or so. And a band keratopathy, I think I'll show a picture of it, but that's the calcification that occurs in the cornea after extensive irritation of it by the crystals. And then there's a distal vacuolar myopathy. I'll show you pictures of that too. So I should just go down this list now. And swallowing difficulties because of the muscle issue, and also lung restriction because of the muscle issues. In other words, we need our chest muscles, our thorax muscles, to open up our thorax to breathe. And if you have weakness there, you can have decreased pulmonary function. So occasionally, we know of a few people who've had nodular regenerating hyperplasia, a liver disease, some coronary artery calcification that may be related to the uremia, and diabetes. And the pancreas can also lose its exocrine function. You know, the pancreas also provides enzymes, especially for the degradation of fat and the absorption of fat. So we've had some patients with that too. Again, these are complications in patients who are older and who largely have not received cysteamine. low testosterone and azoospermia in males, and some bone abnormalities. So let's talk about the muscle, for example. The characteristics are weakness and atrophy, not pain. And it starts in the fingers, and then it moves towards the center of the body. And it progresses with age. And it's related, the degree of muscle damage is related to the cystine content in those muscles and can be ameliorated or prevented by treatment with cysteamine. And again, that's, so here's the first patient that we defined with muscle disease. And you can see on your right that his hand has the interosseous muscles. So in other words, the muscles between the fingers are atrophied and very thin, etc. And you can see that his face has lost some of the musculature. It looks drawn, let's say. And this is a muscle biopsy showing variation of fiber size, which is a pathological abnormality, and a ring fiber, which means the fiber is being destroyed. And these are the intracellular, boy, it's hard to put it there, but where the arrow is, there are intracellular vacuoles, which are a reflection of the destruction of cells. And then the cystine crystals. So those big, long lines of white are not, that's just a natural birefringence of the muscles. That's normal. But in between, you can see some little sharp crystals there. That's the cystine. Well, you can treat this with oral cysteamine and prevent the progression. Also, exercising to maintain the muscles that you have is a really good thing to do for this muscle. Oh, look at, I've got the screen here. Yes. Okay, so what a dummy. Okay, so one or two patients have actually had a tendon transfer because some of the muscles of our body are needed more than others. So you could take a tendon from one to another, especially in the arm for pronation. You know, that's why screwdrivers are turned in a certain way, because most of us are right-handed, etc. Anyway, and the pronators are more powerful than the supinators, so you want that anyway. Tendon transfer is a possibility. Carnitine is not something that will help this, because this is a late complication. The patients are no longer carnitine deficient once they've had their kidney transplant. You know, the reason they were carnitine deficient early is because of the Fanconi syndrome. And theoretically, recombinant growth hormone could help because that stimulates muscle. And then some of the swallowing difficulty is related to the muscle atrophy because we have muscles in our swallowing mechanism. So if that goes a little bit, then you can have things like pooling, where it's supposed to, the fluid is supposed to go down, and instead it pools in areas around the back of the throat. And then occasionally you'll get two boluses. Swallowing difficulty is a dangerous thing for people because they can aspirate and then get a pneumonia, and that can be very bad. So how do you diagnose this? Well, after birth, in other words, if you don't know that there's a child coming because of a previous child that was affected, if it's just de novo, patient comes in, then you don't have a family history to go on. But the Fanconi syndrome is a pretty good sign that you should look for cystinosis. In fact, cystinosis is the most common treatable cause of renal tubular Fanconi syndrome in childhood. And that involves the poor growth that I mentioned, the polyuria, meaning they want to urinate a lot, dehydration, and acid blood. So you can tell that if you get a blood test with your pediatrician, etc. And then corneal crystals, and I'll show you some pictures of that, and a high white blood cell cystine, which definitively makes this diagnosis. There are some labs that are better than others at doing this, white blood cell cystine, and the gold standard is done at UC San Diego in Bruce Barshop's lab. Prenatally, you can diagnose this by getting a chorionic villus sample or amniotic fluid cells and measuring the cystine. And you can make a molecular diagnosis too to confirm it. So the treatment, again, is replacement of the losses. And for the acidosis, you want to give citrate because that forms bicarbonate. For the rickets, you want to give phosphate. And then you want to give potassium repletion because the potassium is going to be low in the blood because it's all peed out. And water, and sometimes calcium. And then because of the thyroid issues, you give L-thyroxine. And some individuals, some males, get testosterone in adolescence and even later. And some individuals who don't grow up properly early can be boosted with growth hormone. Cysteamine, starting about 6 months after you start it at a good dose, will allow for the normal rate of growth of a child with cystinosis. But it will not allow for catch-up growth. So if you want, if you're, let's say, start treating and the child is, let's say, a little bit below the 3rd percentile, then you can have that child grow along that little bit below the 3rd percentile with cysteamine treatment, but you can't bip the kid up into the normal percentiles unless you give growth hormone. And then there's the cystine treatment, which I'll mention. There are 2 oral formulas. One is Cystagon, and the other is Procyspi, and then cysteamine eye drops. So Justini initiated cysteamine treatment when he gave cysteamine intravenously to a young woman with cystinosis in 1976, published that in JCI. And this is the molecule. It's the smallest molecule that can be efficacious for cystinosis, which is to say the amine group allows it to pass membranes, the sulfhydryl group allows it to interact with cystine, and you have 2 methylene groups, 2 carbons in the middle. If you had 1 carbon, it would be a gas. So you can't do that. So this is how it works. You see that the cysteamine gets into the lysosome, and it interacts with cystine, which is the disulfide. In other words, the 2 sulfurs are together. And it splits those 2 sulfurs so that the products are half of cystine, which is called cysteine, and then the combination of cysteine, cysteamine. And the cysteine gets out by itself, and the mixed disulfide, cysteine, cysteamine, gets out through a different transporter that is still functional in cystinosis. That's called the lysine transporter. So Tom Arkello did a study in my laboratory, which is called an intent to treat study, which means that every single individual that was seen at the National Institutes of Health for 32 years was part of this study and included, and the data were included. And some of those individuals were really well treated. There were 17 of them, which means they started early in life and they had really good cystine depletion. Then some of them had no cysteamine at all, and there was 67 of them. And some of them were in between in terms of their cysteamine treatment. And then he measured the kidney function by creatinine clearances. And one thing about the NIH is, as a research institution, we were able to get 24-hour urines. So the nurses would collect 24 hours routinely. So Tom put this all together. There he is. And this demonstrates the results. So, for example, in the normal case, so these are normal people, kids who don't have cystinosis. They will acquire kidney function in the first 3 years of life at a rapid rate, and that kidney function will then fall off. We all have about 1 million glomeruli, which are the filtering units, in each kidney. We lose glomeruli slowly over life, so I might have just lost one right now. But the main point here is that there's an acquisition of kidney function in the first 3 years of life. So the cystinosis individuals never really achieve that high level of kidney function because they have cystinosis and cystine damage to the kidney before the diagnosis is made. So if you see the individuals who receive no cysteamine, then they actually lose a lot of their kidney function over the course of 10 years when they need a transplant. The ones who receive cysteamine, however, not only have not lost that kidney function in the first 3 years of life, but have acquired it. And that slope, that positive slope in the first 3 years of life, that the rate of that is about 12 to 14 times the rate of kidney function loss in the normals. So for every month that you can diagnose a patient before, let's say, 1 year of age, you're going to telescope that into 12 to 14 months of preservation of kidney function over the life of that cystinosis patient. Okay, and this is a measure of compliance on the x-axis, and the higher the compliance or adherence score, the higher the score, the better is your adherence, and then the age at end-stage renal disease or need for a transplant. So in other words, the better adherent you are, the older you are when you need a transplant. And this is how the patients did with respect to height and growth. You can see that with cysteamine, you can grow parallel to the curve. But again, without cysteamine, you don't. In fact, I give this picture, but I don't have to give this picture anymore because yesterday I met 4 cystinosis individuals who were like 20, 25 years old, and all of them were about 6 inches taller than I am. But I forgive you. Okay, so it's spectacular that you can grow like this. Also, other tissues of the body. So this is a kidney of someone who was untreated. On the, I guess it's your left, and on the right, a patient who died of lymphoma with cystinosis, who had been treated well, and there are no crystals there. This was approved in 1994 as Cystogon. And then this is just a summary of how well cysteamine does, oral cysteamine does for the different complications. And I guess a couple of the complications we don't really know that much about because they're so rare. But it does help the muscle issues and the diabetes and the myopathy, et cetera. So I'll show you a demonstration of that too. About 10 years ago, and I think Galena did this work, we looked at 100 patients that we had seen at the NIH over the years, and 61 of them had received cysteamine for less than 8 years, and 39 had received cysteamine for over 8 years. You'll see that their ages, the mean ages of these groups are about the same. And you can see that the ones who received cysteamine for over 8 years had received it for, on average, 15 years. So that's a really good amount. And of those 100 individuals, the ones under age 8 were transplanted. 100% of them were transplanted. And the average age was 11. For the ones who got more than 8 years of cysteamine, only 79% were transplanted, and at an age about 4 years later. In addition, the ones who were well treated or long treated had only 2.2 extra renal complications, whereas the ones who were poorly treated had 4 complications on average. So early and adequate oral cysteamine therapy allows for a normal growth rate, preserves thyroid function, I didn't show you that, prevents a lot of late complications, helps maintain kidney function, and still, because there's some damage done before a diagnosis is made, most of the individuals eventually require renal transplant. And now it's in the 20s and 30s, whereas it used to be about age 9 or 10. Cysteamine side effects, some of them are bad. I mean, you know better than I do how sort of disgusting this smells and can cause nausea. And there are some patients who about 10, 12 years ago or so had some vessel issues. And I haven't heard about that recently at all. Those were very highly dosed individuals as well. Has to be taken every 6 hours as Cystogon, but the Procysp only every 12 hours. So one thing about this oral cysteamine is it doesn't get to the cornea of the eye because there are no vessels in the cornea of the eye. So you have to deliver it topically, right on the eye. And we did some studies with Dr. Kim Kaiser, and Ernie Kuhl was the photographer, and it was really critically important for this. Then Dr. Katerina Tsilu, and then Rachel Bishop. And altogether, we found some wonderful results. So, and by the way, I just want to show you the band keratopathy. This is calcium on the cornea because of the irritation over the years, and this cannot be treated or removed with cysteamine eye drops. This requires a surgical procedure, and you don't want to get there. So, one of the major issues of the value of the eye drops is preventing something like this. So we created, actually, the eye doctors created a library of corneal crystal densities, and you can see the scores go from 0 to 3 with increments of 0.25, and they increase in the amount of crystals that are there. So, and if you give eye drops, you can dissolve the crystals in the cornea of patients with cystinosis, and you can do it at roughly any time in the patient's life, as long as they don't have the band keratopathy. So you can see that in the upper left, after 16 months, there's real clarification of the crystals. And in the bottom right, someone was 37 months old, and 12 months later, look at how much clarification there was. So this is like what we would call a miracle. How often do you get dissolution of crystals? I mean, it's spectacular. And if you plot this, this is a plot with age on the bottom, and then the ordinate has crystal score. Remember, if I said 3 was the highest crystal score? So on this graph, you can see where 3 is. And the line there, the curve that goes up and then levels off, that's the natural history of cystinosis eye crystals. And each individual is represented by one of those lines. So, and the top circle is before cysteamine treatment, and the bottom circle is after. So look at how each of these individuals' scores or crystal densities has been reduced. This is almost like rain falling. And I can just show that again here. You can see clarification. It was approved by the FDA in 2012 after the company, which was Sigma Tau Pharmaceuticals at the time, went and took the NIH records and put them into FDA shape. In other words, we're academicians at the NEI. We just want to see that it helps. But you need a company to take the stuff to the FDA, so they put it in the right format electronically and got approval. It took them probably about almost 15 years, because they started in 1995. That's how much they invested in it. So it's pretty spectacular, but approved. So oral and topical cysteamine help. It's really good to diagnose early. Cysteamine should be given to all ages. Again, the frequency of this is 1 in 100,000 to 200,000. It's a recessive disorder in terms of what's the chance of a cystinosis individual having another child, a child with cystinosis. It's not much, because that person would have to marry someone who carries an abnormal CTNS gene, and only 1 in about 200 individuals in the general population has such an abnormal gene. But I think you know that if a couple marries and has a child with cystinosis, then for every subsequent child of that marriage, there's going to be a 25% chance of cystinosis. So yeah, this is the gene. It's, I'll show you a picture of it. That'll be better. But the point is that sometimes we have a better chance of making a diagnosis molecularly, because half of all the individuals in Northern Europe or of Northern European descent will have this particular 57,257 base pair deletion. So you can look for that and have a reasonable chance of finding the gene. This is a picture of the gene. It's got 7 transmembrane regions, which means that its amino acids are incorporated into the membrane of the lysosome 7 times. And then it's got a tail on each end. Newborn screening, you know, the one incredible issue with cystinosis is that while cysteamine helps all of these things, if you got to give it early. And I told you about the importance with respect to renal function. But when do kids get diagnosed with cystinosis? On average, it has been about 14 months of age. And by that time, you've lost a significant amount of your kidney function, maybe 30%, maybe 40%, something of that sort. So you might be destined to get a kidney transplant, sort of depending upon your size and things like that, how well you take cysteamine. But if you can make a diagnosis at birth and start within the first month or so of life, you can have preservation of the filtration function of the kidney. And there's even recent evidence that we saw yesterday of preservation of the tubular function, meaning you might be able to prevent some of the, or some or all of the renal tubular Fanconi syndrome. And I mentioned this already. Newborn screening programs do not use, they're just beginning to use molecular diagnostics. And you can't use the standard newborn screening program because those programs are based on finding diseases because there's too much of a certain compound. And they detect that by a special mechanism, mass spectrometry. So they take a blood spot and then they measure the increase in that. You can't do that for cystinosis because the increase in the cystine, which is in the lysosomes, is dwarfed by the normal amount of cystine that's in the blood, that is the plasma. So the increment, so this much cystine is in the plasma, and then for cystinosis, it's this much. You know, it didn't move. Okay, so anyway, you got to use molecular screening for this, and that's coming, and it was done in Germany, and they found 3 cases, and so I think that's going to be around in the next, let's say, 5 to 10 years would be my. So, the history, 1955, all the kids died with cystinosis. You know, there was essentially no treatment, didn't even have a kidney transplant. But now, there's possibility for gene therapy, there's possibility for molecular newborn screening, and it's conceivable that some of the future kids with this will live to not have a transplant. That's conceivable. Here is a little baby of one of our cystinosis patients. The one on the left is the mom. The babies are perfectly fine. You know, the mothers have a little risk involved in giving birth, but they've been very well. We heard that yesterday. And some of our younger individuals who want to be cowboys turned out to go to college instead. And this guy, Mason, is doing really, really well. Thanks for listening. There's more. Maybe sometime you want to talk with me.